and no benefit or potential for harm actually in patients who were mild, so not on oxygen, not on ventilation. So when that study came out, it was the results were very positive. And there were other trials ongoing at the same time, and because the results of those studies were the recovery study was positive, the other trials stopped enrolling because now patients were like, no, we want to get the steroid. And so there was about 7 other trials that were ongoing that we reached out to, and we were already in discussions with the trialists, because what happens is if you have too many, we say enroll in trials, but we also want trials to be big enough to find the answer. If you have too many small trials, you won't have enough patients, and then you might not find a real answer. So we started a weekly meeting with the trialists of these other trials, and I don't have the time to go through all their papers and their names, but I have to acknowledge really the great collaboration. So this was part of the WHO Clinical Research Working Group. So we invited them to join us. We said we wanted to see if we can pool the trial data together in order to make the evidence base stronger. So we had the recovery cohort, and we knew there was 7 other trials that had enrolled patients, and that those were going to stop enrolling because of recovery. So it was an opportunity to pool all the data and do a much more robust analysis about the estimates of effect for corticosteroids. And so that was a lot of work and rapid work, because what we wanted to do with WHO's role is to provide trustworthy, transparent guidance. And by trustworthy, it means you believe the process that we went through to write the guidance. And so no longer were we in the early phase of the pandemic where we didn't have the evidence. Now we actually had evidence.
About this specific disease, not based on previous diseases, exactly. Previous estimations, previous practice, but actually something specific to this disease.
So exactly. So then the methods changed. So then we went through a very strict process at WHO. WHO, as I think most people know, develops has norms and standards and develops guidelines according to a very strict protocol. Normally, guidelines here take about 1 or 2 years to develop, because we wait for the trials to finish, to get peer reviewed, to publish, and then we go on a process developing a guideline development panel that looks at the evidence and then formulates the recommendation. And this process, I think if we would ask our colleagues from Quality Norms and Standards, can say it takes up to 2 years. So we don't have 2 years, and of course we weren't going to do that, so we decided to go on a path of the living guidance, which means we're going to go in this robust manner, so do the same thing, get the evidence, which is why we coordinated the WHO REACT, is the rapid evidence appraisal of therapeutics in COVID. And that was what we coordinated for the prospective meta-analysis that has been published today in JAMA that takes the data from the 7 other trials. We brought together the evidence in the meta-analysis, and then we presented this to the guideline development panel, which is an independent panel. The names of the panel members are in the guidance that you can see online, also on the website. And this panel looked at the evidence, deliberated on the evidence, and then came up with recommendations. And I have to also acknowledge this isn't, this is a large team's work. And so I need to acknowledge our collaborators from MAGIC. That's the MAGIC ecosystem that is helping us with the methodological support in order to develop the guidelines faster. And also Jonathan Stern, who is the methodologist from the prospective meta-analysis. So again, just to acknowledge there's so many players here that contributed to this big effort. So fast forward, the guideline is developed, and what we found and what the final recommendations say are relatively 2 recommendations. So all this work for 2 recommendations, and I'll just read them because it's better to read them. A strong recommendation for steroids, systemic steroids, that means steroids, either oral steroids or through the IV, in patients with severe and critical COVID. So that's the first recommendation. And the reason we made this recommendation was because the evidence shows that if you give corticosteroids, you will have, and I'm going through different numbers, so 87 fewer deaths per 1,000 patients. Would that make sense to you? Yeah. So those are the lives kind of saved. So you have fewer deaths.
Simpler, that's around 9 in 100.
Yes.
Of the sickest patients.
Of the sickest patients.
Yeah.
So that's the absolute reduction. The second and so that's in the sickest patients.
So that's something that clinicians who are caring for patients with COVID should do. For those who are the sickest, who are taking in oxygen, either through a ventilator or through a mask, if that's right?
Yeah, and we have...
They should be taking corticosteroids.
And in the guideline, it's very clear how we're defining the severe disease and the critical disease in both of those subgroups, both of those groups of patients.
And these are generally patients who would be hospitalized.
And these are under the medical care of a physician.
Yeah.
Yeah, so I want to be clear because the second recommendation is very important as well. This was a conditional recommendation not to use corticosteroids, so against the use of corticosteroids in patients with non-severe COVID. So that means the patients that are have mild, they may have symptoms, but maybe those symptoms are bothersome, not to discount symptoms, symptoms of mild disease because, those can be very bothersome, but they don't have physiological signs, and I'm going to say that in a scientific way, physiological signs of an inflammatory response that's leading to respiratory distress. The reason we said that was because there was a concern for harm. So the data was less clear on this, but there was a concern for harm in that subgroup. So then, of course, we would recommend not to use it in those patients.
And each time you've been careful to say not to use it in those patients. So you're talking about what physicians should consider using with their patients. This isn't for, even though we're doing this Facebook Live for the general public and everyone's free to watch and ask questions, this guidance is not for us to take home and do or not do ourselves. It's really, this is guidance that's meant for people who are in a hospital setting caring for the sickest of patients. Is that a good summary?
Yeah, and if you look clearly, the guidance is available online, but it is for clinicians and then as well as healthcare decision makers and policy makers, because when we issue guidance, especially strong recommendations, those are things that policymakers can do in order to make this drugs, the intervention available to its population.
Can we just emphasize that point just one more time? Because we put out a lot of guidance and we put out a lot of advice. And so just to emphasize what you said again, the clinical guidance that came out today is meant for clinicians. It's meant for the decision makers who are making decisions about the treatment of patients. So it's not for someone to go over the counter and choose to do it themselves. It's for those who are caring for a sick individual. And as you just said, the recommendation is for severe patients to use or to be recommended to use, but not for the mild patients. So I just wanted to emphasize that again, because our advice sometimes is for individuals, but this one is specifically for clinicians and decision makers.
And another side of that, it's something you mentioned off the top as well, that dexamethasone and other corticosteroids are actually inexpensive and widely available. So there is a risk that people could think, this is something that I can do, because you can actually go and buy this drug. It's not something that's new itself from being developed somewhere in a lab and in scarce supply. In a good way, it's actually widely available to physicians around the world so that those caring for patients in hospital can have access to it. And WHO has actually increased access. You were explaining that a little bit to me the other day as well, that although it's widely accessible, there are some exceptions. There are some places where it's not accessible, and WHO has amassed some doses of dexamethasone for that purpose.
Yeah, so exactly. I think this is for clinicians, but as a patient or as a person in the community, you should be informed, because you will be talking with your clinician when you go see, and if if one was to have severe disease or have critical disease, then this is a therapy that should be strongly considered. The clinician should strongly consider it for that patient. So as an informed person in the community or for your loved one, it's an important piece of information. WHO, we did procure dexamethasone in anticipation of this, that this was going to be, is a life-saving drug, and also has the potential, even though it's widely available, like anything else during the pandemic, the markets has a potential to become scarce, potentially to certain communities or member states, based on the way the markets and the procurement patterns around the world. So just to ensure that there was a stock ready to give to those vulnerable communities that may not have access, we are we have sent the information out to our regional offices that will disperse this to the country offices to ensure that anyone who's not potentially doesn't have some or has a low stock we can assist with procurement and distribution.
Just a few things, a few points of clarification. We're sometimes asked why we're not wearing masks when we're sitting together like this. We're following WHO guidance and what we know from the evidence so far. If you're able to be at least a meter apart from other people, and if you're not in a clinical setting, WHO doesn't recommend wearing a mask. It's not needed.
So good ventilation as well.
And we have good ventilation. It's the door is open and the air is flowing through, and that's another important part of controlling your space. But we do make sure that we're far apart, and that's why we're not wearing masks. The other thing sometimes people ask about this room, this is called the India room, and a lot of the decorations here, most of the decorations were donated by India to WHO when this building was opened. And one more thing, this is Facebook Live and you're meant to be able to ask us questions. So if you are on Twitter, you can ask us questions using hashtag AskWHO. And on the other platforms, Facebook, LinkedIn, and YouTube, you can leave your question in a comment. And so we have some questions already. I don't know if you can pull this up quickly, Janet. Do you know how many patients in the end were involved in this trial, if you added the ones from all the different trials? Was it in the range of 9,000? Is that somewhere around the range of those who were involved?
Yes, I can pull that up. In the meta-analysis, the prospective meta-analysis, there's 1,703. And then if we add on the recovery trial, and I'm sorry that I don't have everything off the top of my head, there was 7,184 patients. So in total, the panel, the GDG panel from WHO that we convened saw 8 trials, evidence from 8 trials, 7,184 patients that were enrolled.
So that was one question we got. The reason we're spending a lot of time explaining this is we get a lot of questions about how does WHO come up with this guidance? What is it based on? Where does it come from? And that's why we wanted to spend a bit of time off the top explaining this, because this is really important. This is life-saving advice that we give, and we can't be wrong, basically. Maria, can you make the leap then to the other guidance we give? It's not clinical guidance, it's not done exactly the same way, but how do we develop an evidence base? How do we develop the information that informs what advice we give people in the end?
Yes, so thanks, Nika. So yes, so we are an evidence-based organization. We are driven by science. And so we have a very robust process for the development of guidance. And in the beginning, as Janet has said, actually our first package of guidance for COVID-19, before it was even named COVID-19, was issued on the 10th, the 11th, and the 12th of January. And that guidance was based on our experience with other coronaviruses, other respiratory pathogens, MERS, SARS, and we issued that, and that is constantly being updated. And the way that we do that is we look at the evidence. We look at scientific studies that are being published. And if they're not published on the specific pathogen, we look for similar pathogens. So for example, we didn't have much evidence specifically on the SARS-CoV-2 virus, but we look at SARS-CoV-1 studies, we look at influenza studies, we look at MERS-CoV studies, and we pull that together. And then we work with huge numbers of scientists all over the world. So we pull together these international networks. Janet is leading on the clinical side. We have laboratory networks, epi networks, infection prevention and control networks, and we bring together specialists from all over the world. We hold these teleconferences where we have a direct exchange of information. And what Janet highlighted on the clinical side is that in the beginning of the pandemic in January, we had clinicians that were dealing with, there were very few patients in the beginning. So we had clinicians who were dealing directly with these SARS-CoV-2 patients, talking to clinicians all across the world. And that's faster than any paper that can be published. So that exchange of information helps us understand what is being used, how it is being used, and what works. We gather all the evidence together, published, unpublished, we discuss it, we debate it. This is a positive exchange, this constructive discussion, and we see how we judge the guidance or the evidence itself, because not all studies are good studies or high quality studies. So we rate them, we grade them, and then we see how that evidence is turned into advice. And then we issue this in the form of these documents that we publish on our website. But even when we issue them, we are constantly reviewing them all the time. So we not only, that's the idea that it's living, and then what you see us publish, it'll say interim guidance at the top, because this is something that is evolving, that is changing. And someone asked me recently, Nika, when is the science going to be done? Like, when are you going to be done with the science? When are the studies going to be done? And that's not how science works. Science is a process. This evidence gathering is a process, and we will always continue to do that. And as Janet had said, we're so grateful to so many researchers all over the world, clinicians, frontline workers, public health professionals, civil society, patient groups who are actually communicating with us, talking with us, and helping us to gather this to turn it into evidence that can save lives.
So I'm not being rude, Maria. I have to check my phone
fine.
even while you're talking to see what some of the questions are that are coming in from our social media team that's monitoring for your questions. We have one on prophylactic treatment. This is Uttam Sinharoy via Facebook is wondering if there are any prophylactic or basically treatments that would prevent you from getting sick in the first place. Is there any evidence towards that at the moment?
We don't have any published evidence of an effective preventative or prophylactic intervention, but there are many ongoing trials. So we look forward to seeing the outputs of those trials, but to date we don't have.
And then that leads to another question we received a few times. What about hydroxychloroquine? Has it had any benefits that we know of, either clinically or prophylaxis, preventively?
Thank you. Sorry, I was coughing before.
It's full service.
So we currently are conducting also a meta-analysis, which means we are synthesizing the evidence of the trials that have looked at hydroxychloroquine as an intervention. And I think we don't have those results yet. So at this point, we had been recommending hydroxychloroquine only to be used under the context of clinical trials because we didn't have a strong sense of efficacy and safety. But we are getting close to looking at a meta-analysis, which is, again, and I think this is an important part because we don't make when you start to write guidance when their evidence is coming, we may not just write it based on one clinical trial. As you saw, we didn't write the evidence just based on recovery trial. We actually pooled evidence from a total of 8 trials. And for hydroxychloroquine, we have to do the same thing. We actually have to pool and do a robust analysis and present this to the guideline development panel. And that's a piece of work that will likely happen, in the very near future to look at that. What will be the updated recommendation on hydroxychloroquine.
Can I add something to that? Because I think it's important that people understand that there's a lot of studies that are ongoing. There are a lot of clinical trials that are ongoing, which are like our gold standard type of study, especially for treatments, because there's a certain methodology that you use for a clinical trial. Because there's so many that are being done. Many of them are really small in size, and they don't have enough patients enrolled in them to get a high quality answer. It doesn't actually get us to that full answer, which is why it's important that we're able to work with all of the clinical trialists, the people who are running those clinical trials, who are willing to work with us to pool the data, which, as Janet explained, means bring together the different data from all of the different studies, pull it together, bring it all together, and then do an analysis on that. Because with so many clinical trials, those numbers are really small, and it's just not enough to get us the concrete answer that everyone wants, that we want. So that's what takes some time. But again, I'm going to say it again. We are evidence-based. We're a science organization, and we need these studies to be done. And we're 8 months into a pandemic. 8 months into a pandemic, to have clinical trials being done all over the world, to have these meta-analyses being done and have these results being given in real time is really incredible. And it's due to the collaboration and the expertise and the critical review and the processes that we have in place that were set up before COVID to rapidly be used, not skimping on any of the quality control, to actually get it out really, really quickly and still be robust.
It's what WHO can do. We have that convening power, and who else in the world would bring together all of these clinicians if it wasn't the UN agency whose job was to do that, basically, to pool the best knowledge in the world on this subject. A few questions on this as well, and this one in particular comes from Ishai Moana on Twitter, asking about long-term effects. So we've been talking about studying medicines and treatments, but at the same time you're also looking at how patients experience and recover from COVID. Can you tell us a little bit about what we're learning and how we're learning more on long-term effects?
So it's a very important question, and it's something that's a high priority for us at this time. The way we are gathering information about long-term effects is multi-pronged, I guess. One is that we, in the clinical network that we have, when the clinicians started to report that they were reporting. So we heard, when we started, they were reporting that patients were having some deficits or limitations after acute illness, during this period after discharge from hospital. And that was not necessarily unexpected, I'd have to say. For the patients who are critically ill or severely ill in hospital, we do see sometimes limitations due to that just being that sick. And some of those limitations range and have been reported between physical limitations, like being stiff or being weak, to psychological complications such as depression or poor concentration or cognitive, not being as clear-minded as once was before, to respiratory complications, which would seem the most obvious because of the severe pneumonia or the need on the ventilation, to respiratory deficits, and then to neurological deficits as well. So I think what we're seeing is that it's not, it's a multi-system, and that's a medical term, but it's we need to follow patients, especially those that have persistent symptoms or were severely or critically ill in the hospital, and do a careful assessment of their symptoms after discharge, see what goes away and what kind of persists longer than what one would expect, and then in certain patients also test physiological limitations such as problems with the heart, the lungs, the brain, psychiatric, and physical, just to understand. But at the same time, it's not just that, then it's interventions, right? And one of the early interventions, which is actually in our guidance, is actually rehabilitation. So doing the care of patients, not just with the ICU doctor or the ID doctor or the respiratory, but actually with a team, which includes an occupational therapist, a rehabilitation expert, et cetera, potentially a neurologist, so that the team finds any potential early signs of a limitation and is able to start doing interventions to improve function. So I think that's quite important. So what we are doing though is we need to understand better. So we've developed, we are in the process of developing a case record form, which is for doctors to use with their patients in order to make sure they collect all the right symptoms for when they see their patients in follow-up, as well as what kind of tests to do with patients in the follow-up. And then also supporting observational research protocols so that patients get followed up in a cohort so that we can actually understand better how common or uncommon these complications are and who's getting them. But there's a lot to learn. And then I think the fourth thing to acknowledge, that we've heard actually from patients themselves who've had persistent symptoms and know that they are out there. So we've had the opportunity to hear directly from patients what they're experiencing and what they're finding challenges in seeking care. So we're trying to address that in the next version of the guidance.
And I think, Maria, I heard this, I've been hearing this from you most often, is actually working with these groups of patients, as Janet said, who reached out to us.
Yeah, so some of the groups contacted me through some social media channels. So I reached out to them and said, can you help us talk to you? Because some of the patient groups are starting to form. And I reached out to one of the groups, is the Long COVID SOS group, and they helped us pull together different patient groups from around the world. And I think these patient groups are forming, and what they really asked for us, it was a wonderful opportunity for us to listen and to hear from, as Janet has said, to listen to the patients themselves. And what they asked for three things. They asked for recognition, that this is something that many people are dealing with. They asked for rehab. As Janet has explained, like how do we help them going forward? And they asked for research. So, the Director General joined our call with them. This was a couple of weeks ago. We heard them loud and clear. We will continue to work with the patient groups. But I think what is really important for us is to understand the extent, what is happening in terms of people and it's not just people with severe disease. I think we do need to recognize that early on in the pandemic, it was very difficult for everybody to get a test. And it really depended on the testing strategy of the country itself. So many people who are suffering, for having these long-term effects may not have had a confirmed test back when. So they want to make sure that they're recognized and that they get the care that they need. And so for us, we work with our member states to ensure that they can get the care that they need and to articulate what that care actually needs. But as Janet explained, it's many different systems. It's not just respiratory long-term effects. There's many effects that need to be researched and studied. And so we're working very hard to do that so that we have a better evidence base, again, to make sure that people get the care that they need. But we've heard you, we hear you, we will continue to work with you.
This is two questions that are related. Fidele asks, can you comment on the reinfection rate? What are the risk factors associated with reinfection? And then Alberto asks, how many months do you know that people have immunity after having COVID? So this has been a recent topic with people getting COVID, seeming to recover, and then there are a few cases of people seeming to get the disease a second time, so a second infection.
Yes. So yes, what we understand from all the research across the globe is that when people get infected with the SARS-CoV-2 virus, that their body develops an antibody response, an immune response. And we are seeing this consistently across studies. People with mild disease, people with moderate disease, even people with severe disease, even people with asymptomatic infection. So even people who don't have no symptoms at all, will develop an antibody response. What we're trying to understand more consistently is how strong that immune response is in an individual and how long that immune response lasts. Does it last for months? Will it last for years? Will it last for even longer than that? So we're only 8 months into the pandemic, so there's only a certain amount of follow-up that we've had in the studies. And in many studies, in some studies, there's not a huge amount of research yet, but in many studies, we are seeing a consistent antibody response over time. So somebody who is infected, they develop an immune response, and that antibody level stays pretty consistent. In some studies, we see a slight decline. With the example of reinfection, we've recently we've seen these case reports of possible reinfection from a couple of countries. There's one in Hong Kong that was confirmed through sequencing, which means that the first infection, there was a full genome sequence that was done, and then the second infection, there was a sequence that was done, and it looks like a different infection.
You can compare the sequence
you
of
can
the virus.
compare the viruses, and you can say this is the second infection. There's another example in the US that I'm aware of. It's in a preprint, so this is a paper that has not gone through peer review, but we're aware that there may be another example of a reinfection in the US. And I think we will start to see examples of this as we go forward. But it's important we put this into context because we've had 25 million plus cases to date. And we're starting to see examples. We may have 1, 2, 3 examples of reinfection, but it doesn't seem to be common. What is really important is that we look at the immune response in these particular individuals. Did they have an immune response from the first infection? And at the time of the second infection, what did those antibodies look like? Did they decline? And if so, why? Were these immunocompromised patients? What are the characteristics of that? So it's too early to make any big, broad, general statements other than we do have some examples that people can be reinfected, but it doesn't seem to be common. But we're very grateful for the countries that are able to do the sequencing over time, and not everybody can do sequences, but that does help us to determine if it is indeed a second infection or if we just see prolonged PCR positivity in some patients, which is also something that we do see.
And so then the advice for the general public, even if you are someone who's recovered from the disease?
Yes, you need to apply the same individual measures, the physical distancing, the hand hygiene, the respiratory etiquette, wearing a mask where appropriate, all of the measures that we say put in place, please continue to do so.
I think some people might look at this and think this is really strange. Why can you catch this disease twice? But there are other diseases, yes, even other coronaviruses that you can catch twice.
Yes, so there are several coronaviruses that circulate. There are 4 coronaviruses that are known for like the common cold,
and you can catch the cold.
And you can catch
more than once,
the cold
as we've all had.
More than once. There's not great surveillance for the common cold. We don't regularly test for that.
Yeah.
But people can be infected with the common cold more than once. With the other SARS-CoV-1, which was in 2003, and then the MERS coronavirus, which emerged in 2012, What we learned from those two coronaviruses, for the first SARS-CoV-1, people can have an immune response, antibody response for years. For MERS coronavirus, we have examples of people, even with severe infection, that their antibodies decline 10 months after 12 months of infection. So again, we base our understanding of what may happen for this particular coronavirus based on past experience, but there's really good research that's being done. So again, our expectation and our experience is that if somebody is infected with this virus, the SARS-CoV-2 virus, that they do develop an immune response. We're learning how strong that is and for how long that lasts.
So that was the question from Alberto, who wanted to know how long that lasts. We're going to have to wrap up today. This is a bit of a shorter Facebook Live. Usually we go a bit longer, but today we have some constraints. We have to hop off shortly. I'm going to go through some of the countries where you've joined us from. On Facebook, from the US, from the Netherlands, Canada, India, Bangladesh, South Africa, Iraq, Kenya, Spain, Malaysia, Indonesia, Cote d'Ivoire, Rwanda, Somalia, the Philippines. On LinkedIn, Peru, Honduras, Spain, Germany, India. I'm not being complete, I'm just selecting. Mexico, Morocco, Lebanon, Greece, Sudan, Tanzania. India, Saudi Arabia as well. So thank you very much for joining us today. Congratulations, Dr. Diaz. I think it's pretty amazing what the crew was able to do today, and we're really proud of you. Thank you for being with us as well, and thank you as well, Dr. Van Kerkhove. See you next time.
Thank you.
Thank you.